ventilation and hemodynamic monitoring. First talk in that first interview and panel discussion would be about ARDS, what has changed and what's new in ARDS. I would welcome Dr. Arindham, who is the Chief Intensivist from SN Reliance Foundation and is also the General Secretary of ISCCM. Interviewee would be Dr. Rajkumar Jupally, who is the SICU in charge at Apollo Jubilees, Hyderabad. So over to you, Dr. Rajkumar and Dr. Arindham. Please take over.
Hi, I welcome all the delegates to the talk. Thank you, Hyderabad ISCCM, for giving me this opportunity. Hi, my name is Dr. Rajkumar, working in Apollo Hospital, Jubilee Hills, Hyderabad. Today, we are going to discuss regarding the ARDS, what's new in ARDS and what practical issues we face at the bedside. ARDS is a life-threatening condition characterized by intense inflammation in the lungs and refractory hypoxemia. Despite advances in the technology and the increase in number of critical care physicians and the critical care beds, the mortality is still high. ARDS has many pharmacological and non-pharmacological treatments. Before we dive deep into the technical aspects and other issues, let's welcome Dr. Arindham Kar. Dr. Arindham Kar is Dr. Arindham Kar is Chief Intensivist and HOD at Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. He is the National General Secretary of Indian Society of Critical Care Medicine. He is not only well recognized in national ISCCM, but also he is recognized internationally. He was former representative from Asia Pacific region to European Society of Critical Care Medicine from the year 2015 to 2018. So let's welcome, sir. Hi, sir. Thank you for participating.
Hi.
So shall we start the discussion, sir, on this topic?
Please go ahead.
Yes, sir. Lot of definitions has evolved in ARDS, like acute respiratory distress syndrome, right from starting from 1967 to present 2012 Berlin definition. Do you foresee any changes in the present Berlin definition? And if so, what parameters you would like to include in this present Berlin definition, sir?
Quite a good question. You see most of but I will give you a very quick historical and practical background to any definition and a good analogy. The maximum uncertainty or confusion in definition had happened with sepsis, for example, right? In fact, we have had multiple conferences to define sepsis. I was part of one part of it. The same thing happened with the ARDS to some extent, right? It started from, as you said, the late 60s, the Ashburg definition, to all sort of other definitions. Eventually, we progressed towards Berlin definitions. And I was there when the first Berlin definition was actually was declared in the Berlin conference of the year ESICM, right? So and in the dinner part, we were actually jokingly discussing that the more confusion do we have, we try to come up with more structured definition to actually get away with the confusional areas. But as we all know, the change is the only constant thing in our life, right? So we can pretty well expect that in later parts, there would be certain elements which would be either changed or incorporated or deleted. So as of now, according to the definition that we have, I think there would be some sort of structured changes that would be included. Some maybe in near future, some as we would be, I think we would be definitely discussing the phenotypic elements, some quantitative, what would I say? I would say assay, some quantitative estimation of inflammatory markers or mediators in terms of ARDS. So these 3-4 things I am expecting would be in a near future. would be included in the definition itself. But once again, on the flip side of this, Rajkumar, is that a definition has to be universally acceptable, implementable, right, and doable. So the same definition which can be actually applied in one of the finest centers in the world should also be done at the bedside, even in the most developing countries, most resource limited or research challenge setting. So in that way, the other way around, it could be more simplified, right? So let's see what comes. But in my opinion, if you say, I would rather go for a much simplified where and also take into account the etiological aspects, right? And maybe a clinical phenotypic sort of definition. Yeah.
Yes.
So
interestingly, yes, sir. As you said, clinically, the present Berlin definition, like what I was going through, instead of this PF ratio, they have suggested certain novel parameters like PaO2 by FaO2 into PEEP would be a better reflector of the patient status rather than PF ratios. As
you see, you just drive away 50 kilometers from Hyderabad and see how many places can afford to do an ABG, right? So at least at the outset. So if you have some clinical definition and which can also sort of classify the severity of the thing, and that person can decide, okay, this is ARDS and I'm going to refer it to Dr. Rajkumar and send the patient to Hyderabad for a betterment or for better outcome, right? So that sort of thing, to have an universal appeal or universal application has to be there. Or in the other end, in the other end of the spectrum, you come up with a more inclusion of certain things and make it more complex. So something in between we have to trade off.
We expect a simpler definition like that would suit even at the like not only at the tertiary center but also at the primary center, like what you said. Sir. That would be a better way.
But life doesn't go as you expect, Rajkumar. It always gives you all the challenges. Fair enough.
Very true, sir. Very true. Shall we proceed to the pharmacotherapy, sir? Like we have been using many drugs. But in spite of using many drugs, newer and newer drugs are coming into the management of ARDS. Let's discuss the most commonly used drugs and widely abused drug also, such steroids. So, do you recommend usage of steroids in early ARDS as well as like in early moderate to severe ARDS? Are the results of like different trials applicable? Can it be implemented at the bedside? And what are your views on this, sir?
So I would rather say the trick question, right? We all know that these are all immune dysfunction. The way the lung injury develops from either a pulmonary or extrapulmonary insult, and eventually there are involvement of everyone. The pulmonary epithelium, the interstitium, the endothelium, and all others, and hundreds of inflammatory cytokines, mediators, both humoral, cell mediated, and all this thing happen. So definitely we have to have to regulate the immune system itself, right? So this is the very, very basic thing. And what falls short is our understanding of the process. Despite improvement in the physiology to the extent of where we can do electron microscopy, electron video microscopy, and everything, where we can actually see the cell going into and creating the damage, liberating the chemokines, cytokines, and others. Even we can visibly and literally see that thing in video microscopes and others, electron microscopes and others. But despite that, we are still not being able to understand all the intricate pathophysiological process of most of the disease, including ARDS, sepsis, and others. So our knowledge falls short that what specific cytokine at what level has to be blocked to have a better outcome. And to complicate the thing, Rajkumar, what happens is that these are all a cascade process. So one single molecule, which is detrimental to the process in one part, may be actually beneficial to outcome. So sometimes to block that particular one can have a varied butterfly effect. So the problem with steroid, or the good part of steroid, is that we do not know at what dosage or at what stage or at what duration it will have a beneficial effect without having a detrimental effect. In fact, it can have a dual effect in between another patient itself. There is no doubt that we have to have a check on the immune dysregulation. We have to block that part. But at what step, which specific agent will give only beneficial action, we do not know. Till that time, steroid is our best bet. And then what we do on a trial and error method, we had been doing it. If you see all the trials, right from the Italian guy Meduri, who has been a very good friend, and all others, we had been used it throughout an A. So what was the recommendation? Do not give early, but do not be very late, right? So once the fibrosis is there, it won't be very beneficial. Or if you give too early, then the secondary infections or your pro-inflammatory cytokines will have a lot more. So these are the sort of confusion that we have. And if we extrapolate, Rajkumar, our understanding from the COVID, mind it, our understanding of the COVID, which has actually forced many of the bedside clinicians like us to understand or try to understand in detail the pathophysiology. So more and more, you would realize that some sort of anti-inflammatory agents would be required to win this battle. So steroids, maybe we would be giving it in a more specific way and a specified way in future. Till then, we have to rely on certain studies, as we were discussing, to find out the timing and the dosage itself.
Yeah, to add on it, sir, like a recent meta-analysis done by Lin et al. Has suggested that it might result in a reduced mortality, but what they have concluded is that the optimal dose, as you said, the duration, exactly at what time we have to administer the steroids, is still remain unknown, and further studies are required to guide us.
Till as of now, not before 7 days, not after 14 days, and methylprednisolone 1 milligram per kg is going to be the A. And till the activity and higher, you are not on an escalating oxygen dosage, I think that should be a good duration at not more than 2 weeks sort of thing, and stopping, tapering off. But I think it depends on individual patients as well as the severity of illness, which can be assessed with multiple A, and also to some extent a soft indications of steroid could be the pulmonary etiology of ARDS itself, which has got a more direct sort of inflammatory effect on the profound inflammatory effect of the lung itself. But maybe we can also take help of your imaging, your levels of cytokines and others in certain areas. So I think in post-COVID, a lot more understanding and the research work whose good effect or cumulative effect would be expected in coming 22 and 23, where we can have a lot more answers, not only also to the COVID, but also to the lung pathophysiology in difficult, including ARDS.
Yes, sir. Let's hope, sir, some future studies might throw a light on this, so that there would be a formal guidelines whether to use it and at what time we have to use the steroids. And coming to the last pharmacological therapy, sir, neuromuscular blockades. After this Accurasis trial, we had this was a mortality reducing drug when compared to the other interventions what we have done in ARDS. But after this ROSE trial, it was a lot of confusion. So in what way do you look regarding this neuromuscular blockade, sir? What is
Raju,
a
you
practical
see,
way of approach? Like whether do you
yeah.
use neuromuscular blockers or not?
You see, in ventilation, if you see in ARDS, ARDS started with the major trial ARMA, for example. I'm giving a simple example. It started. Do you know that it started as a karma trial?
Okay, sir.
The karma, you are not aware of. It started with karma in internal analysis, K was dropped. And the K stood for ketoconazole. Right. So it was started with ketoconazole plus your lung protective ventilation. So if you see, hundreds of things have been tried. So be it pharmacological, non-pharmacological, and ventilatory. So we have tried all sort of partial liquid ventilation, to APRV, to HFOV, to this, to that, and all others. But you see, as I again re-emphasizing, a simpler approach, what we call the KISS approach, keep it simple and safe. That approach is always good. In that sense, what we do, we are extra gentle with the lung, right? The lung is already diseased. And in that sense, there's no point of weeping the lungs more, damaging the lung more, right? To keep it very simple. And that's what we call in a good term, quote unquote, lung protective ventilation. It's just you are very gentle with the lungs. You give maximum FiO2, which gives you the most accepted SpO2 saturation, right? Your lung is bad, your lung is bilaterally white and all these things. You cannot expect that lung to produce 100% of saturation, right? So you accept 88 to 90, your patient will still survive. And Corona has taught us that even with 60, 70 saturation for months, patient can still survive with all the impact cognition and the organ functions, right? So you accept, let's accept 85 and above saturation. Don't try to push hard. The best possible PEEP, which allows you to reduce the FiO2 below 60%, because we know the oxygen can be deadly in form of superoxide ions or deabsorption atelectasis or some others, and provide proper synchronization of the patient. So what happens is that our lung system, be it our gentle 300 million alveoli or the J receptors, or if you have read in detail about the structure of the lung, right, the fibrous structures and all others, they were never destined to have a positive pressure. It is unphysiological, impractical for the lungs to receive a positive pressure ventilation. So our body system, unless and until we are deeply sedated, it is very difficult for us to accept positive pressure ventilation itself, right? So there would be always asynchronization. To ensure synchronization and further reduce all sort of traumas to the system, I think in a very difficult patient and a profound ARDS, severe ARDS and others, it is practical to use muscle relaxation. And it has, before those studies, we had been used it for years. But what had happened? We had used it for a prolonged period, introducing the side effects of prolonged neuromuscular blockage. So the prudence is that use it for the time period, and once your patient has accepted to some extent and the inflammatory part has come down, start to wean it off and come back to the either a sedation or a more acceptable or synchronization friendly modes in that way. So I think that practically this everyone of our generation who has started ventilating way back in the 90s or the mid 90s, we know that this has worked. And the last thing, if you say 3 things have given you a positive mortality benefit in ARDS trials. One is your lung protective ventilation, second is proning, and third is neuromuscular blocker, and maybe the fourth one is fluid restrictive strategy sort of thing, and again a moderate or an optimal PEEP. So these are the 5 things which have given you a proven benefit out of things. And tell me, Rajkumar, all the 5 things are practical. All the 5 things
I think
are simpler things, right? Nothing fancy. None of the fancy things have given you benefit. According to all the studies you do quote, right? All the studies, none of them have shown you on it. So it is always the joy of doing simpler things, but consistently doing them and doing what we call the primum non nocere, not doing more harm to already damaged lung is the most important aspect.
Yeah, dysynchrony can aggravate already the damaged lung, what has happened because of pneumonia or either indirect injury also. So probably like practically it's better to go on with neuromuscular blockades, but we should discontinue it like if it is not required rather than continuing it for a longer duration and like resulting in other problems like critical illness, myopathy and neuropathy.
The critical illness myopathy, we always need to, Rajkumar, understand that this is sort of inevitable thing, even if you are not using neuromuscular blocker. So not only this, secondary infection, steroids, polymyxins, right? Then your sepsis itself, secondary sepsis from prolonged therapy. So multitudes for hypophosphatemia, many things add up to it. It's not only responsible for neuromuscular blocker. And what happens in Indian system is that the lesser number of people working in the day. So you do not have, not all the units do have
adequate staff.
Number of nursing staff, physiotherapists, or that level of tolerance. Here what we do is that within first 12 hours of intubation, if the patient is not absolutely very bad, we have this bicycle impedance systems and others. We start doing the passive physiotherapy by sort of cycling, then very active mobilization during being intubated. So all sort of things that all the developed setups do cannot be extrapolated in the in all the segments of our country. So that those areas that we have created, the paraphernalia, the associated factors, right? So there is no magic bullet in ventilation strategies of ARDS. It's an cumulative effort of every single peg of the system and to its highest efficiency and bring out a patient out of it.
Yes. As we discussed ventilation part, let's move on to it, sir. Sir, regarding prone ventilation, how would you choose a patient who would benefit from proning, and how soon you would like to prone this patient, and what is your routine practices in your center, sir? And your last thing, your opinion on this proning teams, what is practiced in some hospitals when the number of patients of ARDS are more. There are some proning teams who do it regularly, they are used to do it.
Okay, I think a lot had been learned during proning, right? The Italians guys were so Mancebo and others, they were so gung-ho about prone for so long, right? And we didn't take heed. Lot many things where people thought this is impractical, despite the evidence was on your face. So it took 2 trials and a pandemic to give proning its due respect, right? So we all know, and we do it every night. Karvate badalte hai hum log, hai na? So we do it every night. It's completely so physiological, and the explanation of the benefit of proning is so on your face, on obvious that it is the easiest thing to do. And I think the proning, the benefit and the implementation of proning should not be time bounded. The moment you feel that this is the opportunity and the FiO2 requirement is going up, it is always better to restrict your FiO2 than to prone the patient, because it's just like a physiological fluid challenge by a PLR. You are not giving the fluid, but you're still getting the benefit of the PLR, leg raising test. So same thing. You do not escalate your PIP to your FiO2 to 100%. Rather, keep it 60% and prone the patient. So earlier, the better. And that the classical PF ratio less than 150 and others, do not rely on that. Go for your gut feeling, right? The patient is progressing. the ventilation strategy not working, the FiO2 increasing, it is reaching above 60%, you have to escalate your PEEP, the lung shadows are going bad, the lower areas are bad, there is a sparing of the upper areas itself. So in those cases, go early for the proning itself. Regarding prone teams, right? So the idea came from including more muscular, well-built people in the team to help in the day. But also on a more serious side, it is actually the more you have the prone teams or patients in a, you can reduce. It is a good idea, and every big hospitals have implemented that. At least in every shift, there are prone experts, right? Prone parts, what we call, and in that way, the physical complications, the device-related complications and others have reduced. We have in the initial period when we were doing it, many tubes and lines came out. There were your cardiovascular sort of complications, arrest, many sort of things had happened. But now it is there. And even people have also sort of improvise themselves in lateral prone, semi-prone, your awake prone, then you're in the hyper-obese patients, there is a sitting prone. So many things had happened. And I think, and we are improving. So these are all things which are freely available in internet, that how to improvise, or you can use your own intellect and come up with an improvisation. But the basic thing is that you have to change position. You have to give the not so involved portion of the lung a better ventilation perfusion ratio, so that whatever the lung is remaining, you're utilizing that part for a better ventilation. And be safe and be careful and be ready to improvise to achieve the best possible posture for your patient. And please involve the team members, but before implementing the proning position, teach every one of them the technique and also the repercussion of position changes in such fragile patients. So that is most important.
Yes, sir. I agree with your views, sir, on proning. Like the bedside intensivist who's looking after that patient is the best decider, like when to prone this patient.
Rajkumar, you are free to disagree with me at points, right? So, definitely, yeah.
Yeah, sir. Next question is on like ventilation. Like, can we do an ultra low tidal volume ventilation, the ultra protective ventilation, and take the help of ECOR to minimize this barotrauma to the lung, ventilator-induced lung injury, and the effects of increased carbon dioxide and the increased intrathoracic pressure due to PEEP on RV, the right ventricle, is also to be looked on. So, what are your views on it, sir?
You see, in the mid-80s, the concept of baby lung came. That means that the portion of the still not involved lung, uninvolved lung remaining, right, which can take part in effective ventilation, is so small that it looks like a lung of a baby itself within the adult body. So that's the concept of baby lung. And in baby lung, what we came to know, right, previously before, you see, the leading to the ARMA, there were 4 trials which happened in different parts of the globe, including the Amato and this Andre Esteban, he did it in Spain, Amato did it in Brazil, and all others. So they actually chose different levels of tidal volume. And in this ARMA trial, they took heavily the cue from all those 4 trials and came up with a concept of 6 ml per kg, right? So after that, everyone was happy, and all other 6 ml per kg and all everything we accepted. But there were certain trials who were still not happy, researchers, that they thought one size should not fit all. So 6 ml per kg is okay with mild to moderate situations. But what about severe, very badly affected lung, almost no lung? So these things were all evident in COVID itself, right? So even in that situations, even 6 ml per kg is too high. So in desperate time, we need desperate measures, right? So you reduce further. So the reduction part was the first. So what we came up with that idea that let us reduce the tidal volume. The reduction of tidal volume, how we can compensate? The first compensation was to increase the respiratory rate, but still the minute volume is inadequate. The repercussion of it is hypercapnia. So then we gave the term that, okay, accept that hypercapnia, permissive hypercapnia. Still how long? Okay, still 7.15. If it is very bad, what you do? You give a little bit of bicarbonate and increase it. But again, we understood that even giving bicarbonate has its own physiological effect. So then we thought that what we can do. Then we thought that, okay, we can do an HFOV where the tidal volumes are ultra less, but it's almost like a 300 minutes time sort of thing. Or we give APRV where the tidal volumes are less, but the rates are pretty high and all others. So we tried all the permutations and combinations. Everything was to reduce the inflation pressure or whatever you call the driving pressures in the lung itself and to reduce the further injury to the already damaged lung. So eventually, I think it was a natural conclusion to come up with an ultra low tidal volume, that means around 4 ml per kg, right? 4 to 6 or even below 4 ml per kg. And for very bad lungs and whatever the repercussion of high PCO2 and low pH, that you have to deal with extracorporeal theory, extracorporeal removal. So the first extracorporeal carbon dioxide removal, right? I took a very extensive training in Germany itself. It was launched mostly for the COPD, the supercapnic patients, the PCO2 above 150 even, right? In those days. So, and it was initially a pumpless, what we call the pumpless PALP and the pumpless Nova Lung. It started with Nova Lung and others. So, and in India, Dr. Mani, he did the first case in way back in 2007, 2008 and a VIP patient. And that, but the indication was acute exacerbation of COPD, or in Europe, it was mostly COPD, asthma and all others. Again, the Italians are obsessed with the ARDS strategy and others. So what they did, they came up with some certain machine designs, which gave the concept of simple extracorporeal carbon dioxide removal. Parallelly, there were improvement in the design of the ECMO machines, which are now much more versatile, which can do right from your extracorporeal carbon dioxide removal to a VA ECMO itself, or even and certain machines can do both separate ventricular assist and all others. So these designs improved, but the most improvement happened by a very tricky guy in Italy who incorporated the concept of carbon dioxide removal within the dialysis machine system. So think of, you do not need a ECMO machine, you just need a dialysis machine and a neonatal membrane oxygenator and an adequate flow around 200 to 250 mils per minute, right? So what happens is that the physiology is that carbon dioxide is more diffusible, so it needs 200 times more diffusible than oxygen. So it needs a lower flow to come out of the body itself. So if you want to inclusion of oxygen, you need higher flow. If you have a lower flow, the carbon dioxide is diffusible, it will come out. So you use a dialysis machine, use a neonatal oxygenator. Why neonatal? Because the resistance would be much lower. In that case, it would be easier. And you can pretty well do it in your dialysis machine. I did the first one in India, where we incorporated this one, right? It was more of a desperate measure, but it worked. And it is now many of the people are doing. The problem is doing it with a dialysis machine is that the moment you stop it, because it's not permanently removing, the moment you stop it, right, it becomes again the carbon dioxide climbs up. So that's why if you have to have an effective ECOR, it has to be continuous. We have solved that part also. As you know, Rajkumar, we can have now extended sled, right? We can give the sled machine a little rest, or we can charge the battery and go on continuing with the sled itself, or we can do it even with a CRRT machine. So this sort of improvisations can happen. So this is.
Yeah, we had an experience with ECOR, sir. We have done about 5 cases here, same in the ARDS group of patient. But recently, the practical issues what we are facing is the availability of neonatal oxygenator. When compared to the previous days, like post-COVID, the availability of neonatal oxygenator is decreased.
No, it's not decreased. We have consumed it, right? Everyone has consumed it, because I think I did it in the first time in around 2012, right? And I had a detailed discussion with Dr. Mani. I learned it in Florence and came back to India and implemented it. In fact, it was the first triple therapy in globally where dialysis, ECOR, and cytokine removals were happening in together. 2 patients survived on that part. So we did a good day, but somehow I think it's more of a time. If you have a proper dedicated ECOR machine, the process is much sustained, and the process is much easier, and the results are much more sustained. So that part has to be of course, everything has its own effects and side effects. So if you are using a simpler machine with the simpler things, there would be difficulty. So we have to accept that part also.
Accept that. Yeah. So coming to the last part, like what are your views on esophageal pressure monitoring, especially like obese patient when you are confused regarding the titration of the PEEP? Like what are your views on using the esophageal pressure monitoring? Is it practically possible to titrate the PEEP using this machine?
Rajkumar, the main possibility is the titration of PEEP, or whether you do it your loops or your esophageal pressure monitoring. In fact, we started esophageal pressure monitoring or putting for the NAVA itself. We did that part, putting those your bulbs and all others. But practically, what happens is this patient positioning, repositioning, then where the exact location. Sometimes now you are also proning them and all others. So how far those are implementable, it's a nay. So what happens is that everyone tries to come up with some fancy things because everyone to make some mark, right? So because simpler things are at times boring. So you always try to do some fancy thing, make your mark and all others. But do they work? Can you? What is your experience, Rajkumar? Have you done it?
No, sir. No,
You see,
we haven't done. We haven't done.
I have survived almost now 24 years in ICU, right? So we started with the Sur ventilator, which sounded like a huge piston in a boiler. I started with that, and then I progressed to everything, right, from your all sort of HFOB, which sounded like a steam engine machine, right? So partial liquid ventilation, to APRV, to bi-level, to ECOR, to ECMOs, to VA ECMOs, to BiPAP, and even all those things, your NAVA. In fact, at one point of time, we tried to visualize the lung through electrical impedance and all others, right? And then accordingly to guide our regional, what would I say, the differences that were being created. So there was that sort of technology has also come. But none of the technology actually helped to get benefit. I think the benefit would be more when we come up with certain more non-pharmacological intervention to reduce the repercussion of ARDS and make the lung much better. Till that time, the ventilation has to be very simpler and primum non necessary.
Yeah, okay, sir. Thank you, sir. And like any concluding remarks and any message to junior colleagues like regarding this ARDS? And especially the number of studies that are coming out every year. Each study tries to give a different message and a contradicting message when compared to the previous well done randomized control trials. So, what is your advice to the juniors and students how to take these studies, especially in the ARDS?
First of all, I still consider myself junior. सोच सोचने में अच्छा लगता है जो उम्र नहीं हुआ है, right? To be on the lighter side, and but so it's my message or my humble suggestions to all my colleagues, right? You are all are my colleagues. No one is a junior or senior in that task. First of all, try to be open, right? Try to accept many things, right? But do not be over enthusiastic and jump in the day. Right? Always age-old things are much better. But reading through all the materials that come to in a critical mind or as well as at the same time on an open mind broadens your horizon. So that gives you much more the wisdom, right? But wisdom comes at an age when it is of no use, right? This is the famous words of Gabriela Garcia Marquez. So you have to acquire the wisdom at a much younger age, unlike me, and apply it in likewise. Regarding the ventilation strategy of ARDS, I think we all know that there are now phenotypical subgroups or subtypes and all others. Maybe the way what we have progressed in oncology, right? So in oncology now, everyone is a individualized precision medicine. I think at a time will come, then it would be a individualized precision ventilation prescription for ARDS itself, along with very specific immune-based therapy or a immune regulation therapy. So that is going to be the future of, not futuristic therapy, I'm talking about the future of ARDS management itself. A specific ventilation prescription, so start using it, a ventilation prescription individualized for your individual patient, which will include everything, right from your oxygen to your PEEP, to your position, to your monitoring and everything, and make it sort of, what happens is that your contact period with the patient is much less. So explain it to the people whose contact period is 24/7, right? So whatever your knowledge is there, the highest level of knowledge is not translated to the bedside unless you also make them knowledgeable. It's a separate story. Once they are more knowledgeable, they leave your hospital and go abroad. That's a separate story, right? But try to make most of the people knowledgeable enough to implement your understanding of the disease process. That's a very important thing. And the second part, obviously, there should be, definitely there would be a much more changes in the immune regulation of the disease process. We will extrapolate our knowledge from COVID itself, and then we will apply it in different lung-related situations, and we can pretty well hope. And lastly, obviously, the reversal of the basic disease process, be it in terms of pneumonia or others, there would be improvement in the anti-infectives and this thing. And lastly, obviously, the basic critical care in terms of infection control, feeding, nutrition, early mobilization, and all. I will reiterate my fact that it is not an individual part. You see, that's the beauty as well as the curse of critical care. It's not an individual brilliance. It's a collective form of the entire team itself. And you being the team leader, you have to take the glory and brunt of both the success and failure. So you have to lead the way. So that's my message to all my colleagues. And let's rock in future. And best of luck to all of you for your future career.
Thank you, sir. Thank you very much. Great words of wisdom, and thank you for a very practical inputs on ARDS.